Namaskar and good evening, everyone. A very warm welcome on this Sunday evening for the webinar on redefining success in CML. With immense pleasure, I would like to invite Dr. Chirag Shah, who is Senior Consultant Hemato-Oncologist, Apollo Hospital, Ahmedabad, for the welcome and introductory note and to take the proceedings further. Over to you, sir.
Thank you. Good evening to all. Good evening to all the faculty and all the audience. After a long time now, we have an exciting drug in CML from the typical, second generation TKIs. Now we have a third generation, a different mechanism of action. And we are all aware in some or the other way that what we have today is not perfect. But since we have come a long way from transplant to a simple oral tablet, we have been in acceptance of what is available is good enough. But from patient's perspective, it is not good enough, and there is still a lot of room for improvement. So we'll see today from our expert speakers. First, Dr. R.K. Jena, who will tell us about unmet needs in newly diagnosed CML. Then we have Dr. Shyam Agarwal from Gangaram Hospital, Delhi, who will talk to us about ELN 2025 guidelines update. And then we have Professor Dr. Martin Müller from Germany, who will talk to us about redefining success in CML, the role of asciminib in first-line treatment. Then we have a discussion where our panelists are Dr. Kaushal Patel from Surat. Again, Dr. R.K. Jena and Dr. Agarwal will join us. And then Dr. Ashwin Rajbhoj from Pune, Dr. Anup Toshniwal from Aurangabad, Dr. Shekhar Patil from HCG Hospital, Bangalore, Dr. M.V. Chandrakant from Kolkata, Pritam Kumar Jain from Mumbai, Dr. Jeham Dabar from Mumbai, and then we will have closing remarks from Sir Professor Dr. Suresh Advani. So with that, let us start with our first talk by Dr. R.K. Jena, sir.
Okay, good evening, sir, and thanks, Dr. Chirag Saha, the program director. The chairman is Dr. S.S. Advani, sir. Dr. Shyam Agarwal probably will be joining, and our international speaker, good friend of mine, Dr. Martin Müller from Germany. So, can I have my slide, please? I'm sharing, just give me a minute. I think this is it visible?
Yes, sir, it is visible.
Yes. So I'll be in 10 minutes, I'll be talking about unmet needs in first-line therapy on chronic myeloid leukemia. These are my disclaimer, nothing to declare. Whatever I am telling, these are all my personal views. The treatment of the chronic myeloid leukemia, one of the important milestone is achieving is of the major molecular response at the end of the 1 year or the deep molecular response at the end of the 2 years, which are crucial for achieving the long-term outcome in chronic myeloid leukemia, including the treatment-free remission. If you look at the percentage of achieving this major molecular response and deep molecular response, imatinib achieves at the end of the 1 year is only roughly 27 to roughly 30% of cases in various studies like NS study, Dacian study, or B4 study also. And if you look at even the deeper molecular response at the end of the 2 years, means 4.5 log reductions, in imatinib it varies from 9 to hardly 9 to 10% cases also. Similarly, with second generation TKI, like nilotinib in NS study, the major molecular remission is varies among different studies, like it varies from 45 to 55%. This is the nilotinib, this is the dasatinib, and this is the bosutinib also. If you look at the deep molecular response at the end of the 2 years, with 4.5 log reduction, it is varies in between a 20 to 25 percentage. So for the second generation TKI is concerned. So in spite of our best development or best so many therapeutic options available, by end of the 5 years, less than 70% of patients still receiving their first line therapy achieve only deeper molecular response at the end of the 2 years. So achieving or potentiating or optimizing the efficacy of the first line therapy is probably one of the most important unmet need at present so far the CML is concerned. Now, second is that if you look at even various studies have shown that the achievement of the early molecular response means BCR-ABL less than 1% or 10% at the end of the 3 months is one of the important surrogate markers for achieving the deeper response and major molecular response and also the overall survival. If you look at that in a 206 patients with retrospective analysis on imatinib, if you look at if the early molecular response at the end of the 3 months, if the BCR able is less than 1%, achievement of the MMR is 40.7%, and the achievement of the MMR, the 4 log reduction at the end of the 4 years is 87.3%. And this percentage gradually decreases as the EMR also gradually decreases also. If it is more than 10% at the end of the 3 months, the achievement of the major molecular response 4 log reductions at the end of the 4 years is extremely low, 18.3 also. Similarly, in NH study also, same thing happens also. Those who are achieving the early molecular response, which is less than 1% or less than even 10%, their achievement of the deeper molecular response is much more higher than who don't. So most importantly, achievement of the early molecular response is correlated with good prognosis, low rate of the disease progression, and deeper molecular response also. And short hopping times of BCR-ABL transcript are also associated with a higher probability of achieving the deeper response. So achievement of the early molecular response and a quick response also is one of the another unmet need because many of the patients they don't achieve that kind of say faster and quicker response. So far at the end of the 3 months this is concerned. This is another second most important unmet need in the CML era today, even today also. As you know, the patients, if you look at the overall survival by the end of the 5 years in CML, the 90% and 95% at the end of the 10 years, it's 85%, roughly 80%. Most of the patients, they have to continue the therapy or the TKI almost lifelong for a prolonged therapy. So long-term treatment may negatively affect the patients with quality of life. There is an increased focus on the quality of life and treatment-free remissions are the treatment goals, which are the two new treatment goals which are considered for that also. So finding a good quality of life, optimal acceptance because the patient has to continue for a long period is also important element so for the management of the CML is concerned. You know, intolerance or the stoppage of the medicine or switching intolerance or the acceptance or the poor acceptance is the main two factors in switching over the patients to the different TKI therapy also. It has been shown that I am sure the upper portion has been covered up by these technical terms, but it is, yes, that's good. If you look at the intolerance and resistance contribute to switching in 73 to 95% of the patients and the primary reason for discontinuing the first line therapy. As for example, if we examine here also, so for imatinib, dasatinib, nilotinib is concerned, the deep blue is the for intolerance and green is your resistance. Roughly 50% of the patients with imatinib or even 40% of the patients with dasatinib and so also 40% of the nilotinib, they have a frequent switching over the other TKI because of the intolerance or resistance. And the real world data has shown that if there is a patient of the 795 patients in a cubic CML registry found that switching more than 2 times is linked to the decreased survival. In general, the more you switch to the TKI therapy, particularly if it is more than 2, the chance of the overall survival is also compromised. Similarly, data from the pivotal study in the newly diagnosed has shown that roughly 35 to 40% they don't adhere. There is a stoppage, there is a discontinuation of the TKI therapy because of the adverse event which varies from 4 to 31.7% or due to lack of efficacy which varies from 3.5 to even roughly 16%. Total together, 35 to 40% patients also they discontinue the medicines also. So intolerance and resistance, high resistance, which leads to frequent switching of the TKI therapy and overall discontinuations to an extent of 35 to 140%. These are the two limiting factors for optimal achievement of the result or the outcome of the so far the chronic myeloid is concerned. So restricting the switching of the TKI therapy and maintaining an adherence or preventing the unnecessary discontinue is probably another important unmet need so far the CML management at present is concerned. Therefore, I would tell you this is another example how if you compare the intolerance, intolerance can lead to intentional non-adherence, reducing the likelihood of an optimal response and treatment. So this blue line shows is that the adherence more than 90%, and this is if the adherence is less than 90%. That clearly shows the probability of achieving the MMR is much more inferior if there is a adherence, if there is a non-adherence, if the adherence is less than 90%. Same thing with imatinib, same thing with the deeper molecular response log. Even if you look at the complete molecular response, if you have a adherence more than 90, less than 90%, it's almost 0% also. So adherence is an important for achieving a response such as major molecular response, deeper molecular response, which are essential for disease, so controlling the disease eligibility. So therefore, managing adverse events by dose adjustment, frequent monitoring, and additional therapy based on the toxic profilability, thereby improving the tolerability of the TKI treatment, can contribute to improve adherence to the treatment. This is another unmet need. How to improve the adherence of the TKI by limiting the adverse drug events and by managing by the dose adjustments. This is another important unmet need. So for the CML therapy is concerned. This is a small example. How we even with the present TKI therapy, only 55% of the patients they tell that they are satisfied. Why do when I say 45 to 50%, they are not satisfied. On the right side, I won't go to this column because this is the concordance rate between the goals or the targets of the patients and physicians. There is a huge variations what the physicians think vis-a-vis what the patient thinks so far the patient's management is concerned. So whatever the main message is that with the existing TKI therapy, only 55% are only satisfied so far their acceptability, tolerability, or adherence is concerned. One of the main reason for the adverse drug reactions or by the complications are that the ATP competitive TKIs have off-target effects other than which causes the intolerance. In addition to the TKI, they also have off-label. You have a nilotinib, they have so many off-label target. Similarly, imatinib, dasatinib, and ponatinib. Not only they block the TKI, which is specific the pathophysiology related to pathophysiology of the CML, even to the many of the kinase enzymes also of the human body. Therefore, that causes a lot of adverse drugs reactions. So switching to another active, here the important point is that if we switch from nilotinib to imatinib, dasatinib to ponatinib, and vice versa anyway, the same off-target inhibitions are going to stay and the same, and you may suppress one adverse drug reactions, but you will have a new adverse drug events also. So switching to another ATP competitive TKI due to intolerance may not be an ideal option to improve the adherence or even tolerability also. So this is the probably last summary of my unmet need. You know, the first generation is imatinib, which is considered as the safest TKI, but it has a very moderate efficacy, but a high level of the safety profile. On the other hand, you have a second generation TKI, you have a very high level of efficacy, but so for safety and tolerability is concerned, is a very, very poor, and the adherence and the discontinuation is, it can go up to 35 to 40% so far the second generation TKI is concerned. So ideally, you need another new drugs. Hopefully, Dr. Martin is going to allude on that. This can be fitted here at the investigational agents with a high level of efficacy, high level of safety and tolerability. Hopefully, this will be an ideal settings. How to potentiate the effect of the optimal outcome so far the chronic myeloid leukemia is concerned, and address many of, and hopefully this new investigational agency is going to address many unmet needs which I have just alluded just recently. I will end it here, and thank you very much for your attention. Over to Dr. Chirag, please.
Thank you, Dr. Jaina, for excellent deliberation on what are the unmet needs. I think it was very self-explanatory. So we'll go to the next speaker, Dr. Shyam Agarwal, sir, about the ELN updates.
Right. So, good evening, Dr. Chirag, Dr. Advani, and all the faculty for inviting me here. So, I'll just briefly rush through the updates which are from ELN 2025 on CML. Can I have the next slide? So, you're all aware of these developments, but the idea is for the students to sort of understand and have some new points. Next slide, please. Those are topics which are going to be covered. So we all know CML is as a result of BCR-ABL1 fusion gene, and cytogenetics and RT-PCR are required. And this is CBA is chromosomal banding analysis on bone marrow, and RT-PCR on the blood and bone marrow can be done. Bone marrow can be deferred as karyotyping is possible now, peripheral blood at diagnosis. BCR-ABL point mutations associated with resistance are usually not required to be done at the time of diagnosis. However, a targeted panel NGS is recommended for patients who present or progress in blast phase. Next slide, please. So how do we monitor the response to treatment? Initially, the BCR-ABL ratio mRNA is monitored every 3 months until MMR is achieved, and then every 4 to 6 months if MMR or deeper response remains stable. Monitoring frequency should be increased if the transcript levels rise or fluctuate, and when treatment discontinuation is being evaluated or followed up in eligible patients. Molecular response should be measured on the international scale, and we use the ABL1 BCR or GUSP as control genes, patients with standard E13A2 or E14A2 BCR-ABL mRNA variants. Previous definitions of disease response levels are maintained. DMR is defined as MR4, which is greater than 0.01, and 4.5 is 0.0032. Meaning thereby that 1 in 32,000 cells are, less than that is positive. Patients with atypical BCR-ABL, which is very uncommon, they need to be monitored on a personalized RT-qPCR because their fusion proteins are different. The chromosome analysis is recommended for patients with rare transcripts not measurable by RT-PCR during suspected TKI resistance to assess additional chromosomal abnormalities or on progression. Next slide. So there are some changes in the definitions. The optimal warning and failure are replaced by favorable, where treatment switch is unnecessary. Warning means the treatment switch may become necessary, and unfavorable means a treatment switch is preferred. Next slide. Milestones of response. Previous guidance to switch TKI on failure of molecular milestones is modified to better consider for individual patient circumstances, and the treatment changes should be guided by clear goals such as achieving DMR to enable a potential attempt to TKI discontinuation. I'll come to the TFR. BCR-ABL1 mutation analysis and a switch to TKI are recommended in patients. 60 years in good health without comorbidities, and for younger patients who can tolerate more potent drugs without toxicity, especially those patients who are pursuing TFR. And we're going to hear more from our guest speaker. Additional molecular monitoring may be necessary when response kinetics are unclear or when treatment is interrupted or reduced due to toxicity or intolerance. Next slide. Talking about resistance and BCR-ABL1 mutations, The BCR-ABL1 mutation testing is recommended in cases of TKI resistance, early signs of resistant progression or diagnosis in blast phase and relapse after allo stem cell transplant if a mutation was present prior to transplant. Testing is not recommended following loss of MMR after TFR, as such relapses rarely involve mutation selection. cDNA-based NGS testing is preferred for mutation detection, as it can be used when BCR-ABL, the log is more than 0.1%, and Sanger sequencing is also acceptable if NGS is not available. Next slide. So the treatment strategies, I think 6 TKIs are approved, and we have 5 of them. The one redotinib is only for South Korea at this moment. This is an important issue. In the ASC first study, asciminib showed superior MMR rates at 48 weeks and 96, 67% and 74% as compared to imatinib, which was 40 and 47% respectively. And second generation TKIs were at 57% versus 56%. So this is what we're going to be hearing subsequently. Adverse events of greater than grade 3 and treatment discontinuations were lower with asciminib, 44% and 5% respectively, compared to 49%, 30% with imatinib, and second generation TKI, 59% and 12.7% respectively. Next. Yeah, so the treatment strategy in second line, approximately 30 to 40%, as was shown earlier, require a switch first line TKI due to intolerance or resistance. And dose reduction is a viable strategy for managing side effects if molecular response is maintained. So that's important. Following first line imatinib, any suitable second generation TKI can be used in second line if no specific BCR-ABL mutation is present, depending on age and other comorbidities. After failure of a first line second generation TKI, switching to another second generation TKI is rarely effective without a BCR-ABL mutation, and therefore early use of either ponatinib or asciminib should be considered or encouraged, although asciminib is not approved for second line use in all regions. Next. After dose reduction, patients should be monitored closely to ensure that the MMR and the response is maintained. However, serious side effects such as pleural effusions or pulmonary hypertension or VOEs, enterocolitis, etc., would warrant switching TKIs rather than reducing the dose. Next. Treatment beyond second line for patients resistant to second line therapy, asciminib or ponatinib should be considered first based on the mutation profile and comorbidities, as both have shown promising responses in phase 1-2 studies. In the ASSEMBLE trial, asciminib showed clear superiority over bosutinib in patients who failed 2 lines of TKI. The benefit of switching between asciminib and ponatinib after resistance is unclear. In such cases, referral for allo transplant should be considered. Next. Next slide, please. For whether in the advanced phase disease, whether ELN or WHO classifications of disease phase are adopted, both recognize indicators of high risk progression in both newly presenting and existing chronic phase patients. Patients presenting in accelerated phase have a better prognosis than those progressing from CP on TKIs, and generally need to be given second generation TKIs. Eligible blast phase patients should receive intensive chemo plus a TKI followed by allotransplant, while non-eligible patients may benefit from low intensity chemo with TKI. Next. So allogenic stem cell transplants use in CML is declined with the TKIs use, but remains vital for chronic phase patients resistant to third or fourth generation TKIs or intolerant to all TKIs, or those who are progressing to blast phase. Transplant of resistance blast phase patients is not recommended outside clinical trials. The risk of relapse after allotransplant for CML rises with increased immunosuppression and reduced intensity conditioning, and therefore myeloablative conditioning is recommended wherever possible. Next. Treatment-free remission is generally safe when performed at centers equipped with reliable molecular monitoring and where patients are carefully selected. Some eligible patients may choose to continue therapy. Clinicians need to, have a shared decision making regarding the follow-ups and regular monthly testings. In highly motivated patients, younger individual or women planning pregnancy who have not achieved DMR, switching to a more potent TKI is reasonable, although there is no evidence that this improves TFR success. Treatment should be discontinued in patients with atypical BCR-ABL1 fusions in high quality. Molecular monitoring is available and have maintained undetectable disease for more than 2 years with greater than 4 log reduction from baseline. So even atypical BCR-ABLs can be considered for TFR. So I think parenting, we all know men can continue TKI during conception. There are no evidence of fertility issues. TKIs are not recommended during pregnancy and during breastfeeding. For patients who wish to become pregnant or are currently pregnant, there are now clear guidelines based on their molecular response. Next. Next slide, please. So with the availability of more TKIs and better understanding of side effects, patient management is focused on ways to prevent and minimize toxicities and improve quality of life through dose adjustments, patient assessment, regular monitoring, ensuring adherence, and maintain therapeutic response. Next, please. So these are the conclusions from the author. In 2025, ELN recommendations reflect significant progress in the treatment of CML with effective TKIs and improved patient outcomes, individualizing care, quality of life, and potential for TFR. Despite the availability of effective TKIs, access and affordability still remain global challenges. These guidelines aim to balance evidence-based treatment and practical considerations, offering a comprehensive framework for clinicians. TFR, long-term treatment, and parenting considerations, as we just discussed. So with this, thank you very much for this opportunity and patient listening. Thank you very much.
Thank you, sir, for a very quick but fairly comprehensive update. There were a lot of learning points for, I think, students. And one that I would like to highlight is that, as you mentioned, there is still access and affordability issues, and options are limited. So optimal use is very important. One of them being dose reduction can be considered after the initial 1 or 2 months, especially if there is difficulties with tolerance, and that way you can get more mileage out of the existing drugs. So with that, it is my pleasure to now introduce our guest speaker, Professor Martin Muller, who has an extensive experience in CML and asciminib, especially, which is of today's interest. So Dr. Martin Muller is CEO of the Institute for Hematology and Oncology and director of the Labor for Hematology and Oncology in Mannheim, Germany. Besides treating patients, his enthusiasm is for integrative hematologic diagnostics, combining morphology, immunophenotyping, and genetics. He became a specialist in internal medicine in 2006 and obtained his habilitation on standardization of molecular methods in patients with chronic myeloid leukemia in 2008. He is a specialist in hematology and oncology since 2009 and has been heading the scientific laboratory and the CML Excellence Center of the Medical Clinic 3 at the University Medical Center in Mannheim between 2010 and 2015. He is co-author of more than 130 peer-reviewed publications and has been appointed as extraordinary professor by the Heidelberg University in 2011. Over to you, sir. You need to unmute Professor Muller. Professor Muller, we cannot hear you. Tech team, can you check? We are not able to hear Professor Muller.
Uday, can we check?
Oh, just wait. Dr. Martin, can you rejoin the meeting?
We are unable to hear you, Professor Martin. We cannot hear you, no. Tech team is suggesting if you can rejoin.
Can you hear me
Yes.
now?
Yes,
Yeah.
yes, now we can hear you. Yes.
Okay, sorry for that. I tried to work with another loudspeaker, which made me hear you better, but now you could not hear me. Sorry for that. Thank you very much for this kind invitation. Thank you so much for having me on this meeting here. And yeah, I will talk about things that have been very well introduced by Dr. Jenna and Dr. Agrawal already, and it's about my perspective on treatment of CML after having 26 years of experience of treating those patients. And so I tried to move forward. Now that works. So here's the disclaimer. We have seen that before. So this is, sorry for the German announcement here, but these are a summary of 4,000, nearly 4,400 CML patients who have been treated within trials in Germany since the year 1983 and up to now. And you see the excellent increase of overall survival, so 5-year survival of 38% in the busulfan study in the year 1983, up to now a 5-year overall survival of 96% on nilotinib. And you see all these trials in between that dealt with hydroxyurea and interferon and stem cell transplant, and coming up with imatinib as the first TKI via nilotinib finally. So I think we achieved a lot, and that many of these achievements were due to drugs from Novartis with imatinib and nilotinib. And now there's a new chapter. And what we saw is that life expectancy is getting very close to what the general population, at least in Sweden, showed. I think this is an experience from many other countries as well. And so just one highlight from the ELAN recommendations 25 that we already heard. I think virtually there was not a change in the hallmarks, in the milestones, that 3-month achievement of less than 10% of BCR-ABL still is a very, very good prognostic marker for future both deep molecular response and less progressions and higher overall survival. At 6 months, less than 1% on the international scale should be achieved. And after 12 months, we want to achieve an MMR in all of our patients. So that means less than 0.1% BCR-ABL expression on the international scale. As you heard by Dr. Agarwal, the wording has been adapted from optimal to favorable, from failure to unfavorable, which I think is quite smart, because as a patient, you don't want to be a failure. And I think that's really sounds more hope-giving than before. why is it so important to avoid progressions? We want to avoid progressions. Why? Because we cannot treat them properly in many, many cases. So if we experience accelerated phase or blast phase, the median survival is less than a year. And so even if we have access to transplant, these are the numbers which are really devastating. So I think my efforts in management of CML, they concentrate on how to avoid progressions. And there are three things which I want to insist on, which should be done at every patient at initial diagnosis. And I'm sure that most of the people who share this session here do that already. To look at cytogenetics at initial diagnosis. And I insist on that because in Germany, more and more patients do not even get a bone marrow at initial diagnosis of CML, which I find really unacceptable. Why is it unacceptable? Because we would miss these additional chromosomal abnormalities at diagnosis, like trisomy 8, trisomy 19, additional Philadelphia chromosome, and so on. Mostly unbalanced abnormalities. And why is that important? Here we see from a German trial using imatinib that those patients, which is the black curve, which I would like you to concentrate on, those are the patients with additional chromosomal abnormalities up front, and they have only a 70% overall survival after 3 to 4 years. So that these are obviously problematic patients, and we should not treat them with imatinib. The second thing at initial diagnosis is to look for the risk scores, and I think SOCAL score is still a very good score and maybe more widely used, but the same criteria, so age, spleen size, blasts, and platelet counts, go into this ELTS score, meaning uterus long-term survival score, which I think is the best score currently used, and everybody could do that via this homepage of the European Leukemia Net to calculate the score and to see, is my patient biologically a good risk patient or is he prone for acceleration. And the third thing I want to insist on is that every patient should get a qualitative BCR at the beginning. Dr. Agarwal already mentioned that, how important it is. The E13A2, E14A2, which are the standard transcripts, only those can be monitored according to the international scale. We should be aware that you need to know if that transcript is present, and you can get international scale results or not. And but it is possible for all of the rare transcripts to quantify them on an individual basis, as being reported before. But not on the international scale. So you can speak of individual log reductions from the individual starting point in those patients. So that is important at the beginning in terms of prognosis as well, because we know that some of the transcript types really are problematic in responding to our treatments. So I would say, if an unbalanced additional chromosomal abnormality is present, or the risk factor, the classification is non-low, so is intermediate or high, or if we find an atypical BCR-ABL transcript, I'm absolutely reluctant with upfront imatinib. That should not be given anymore, because we know that these patients will have a minor chance of getting good responses. So going to the absolute other end, after many years of successful treatment, after achieving MR 4.5 for at least 2 years, the stopping trials have taught us that stopping is possible in roughly maybe 50%, and I'm sure that this experience is more or less the same in your centers as well, that if we have proven to have a really deep molecular response, which need to be done with stringent criteria, then it is safe to stop the treatment, and round about half of the patients will never need any drug anymore in their life, but half of them need to get the drug which they obtained before, or another one. So when we stop treatment, and this is not as recent as Dr. Agarwal's, because it was the previous version of the ELN recommendations, but I just want to highlight that in the last three lines, the optimal recommendation to stop would be if the duration of a TKI therapy was more than 5 years, if a duration of an MR4 is at least 3 years, and then 4.5 duration would be at least 2 years. I think that is still valid and can be taken. So why do not all patients achieve deep response? We are all aware that the world is not that perfect, not yet. And we have also seen from Dr. Jenner, like this beautiful data from the Hammersmith Hospital a couple of years ago, which opened our eyes concerning adherence. And what we saw here is that if you do not take, if the patient doesn't take more than 90% of the prescribed dosage, then the chance of achieving a deep molecular response is really negligible. So the yellow curve patients are those who had an adherence of less than 90%, and those obviously will never go to deep response and will never think about stopping treatment. And why is that the case? I think it is the side effects in many cases. So patients are not satisfied. We heard that before. So on the left-hand side of this slide, we see that 44% of the patients in that CML Sun patient survey were not satisfied with their side effects if they have been managed unsuccessfully or not managed at all. And therefore, I think that is a help screen for us physicians to have a greater look on that topic. And what we wait, I need to move that a little bit downwards so I can see. And the perception of what is important, and that's what also Dr. Jenner said, from patient perspective and from the physician's perspective, is also not really the same as we see. The reason why these drugs are in a certain way dirty concerning not specific for BCR-ABL is seen here. So we see that virtually all of the TKIs who have been approved so far in CML have a lot of off-target effects, and those are supposed to be the ones to cause the different profile of side effects that we see in our patients. And yeah, the summary slide showed that we have imatinib on one side with a lower efficacy but higher safety profile, and we have the second generation TKIs with a higher efficacy and lower safety profile. And the area of unmet need would be in an investigational agent which is both effective and safe. And you know which drug we are talking about. It's asciminib. And here we see on the left-hand side the normal conditions. We see that ABL is normally in a normal person inactive. Here's the kinase domain, the myristoyl site, and here's the ATP binding site. In CML, there's a constitutive activation of BCR-ABL that is unfolded. And we see that we can inhibit it with the conventional ATP binding site inhibitors that you all know, imatinib, dasatinib, and so on. And we have this kinase domain myristoyl pocket. And this pocket is really very specific. And in CML, being inhibited by asciminib, we bring the ABL again into the inactive configuration, which means that it's properly targeted. Why is this so important? Here we see red dots and blue dots. The red dots are cell lines of BCR-ABL positive cell lines. So those who want to be targeted. So if they are on the left side, that's good. And we want to do not want to see a lot of blue balls more on the left side or even have an overlap. And you see that asciminib clearly is distinguishing between targeting on the one side and the off-target effects, which are cell lines, not BCR-ABL positive cell lines. That is a big advantage from a theoretical point of view, but it translates also into clinical behavior of the drug in CML patients. That led in third line to an FDA approval of asciminib in the year 2021 and in 2024 in first line treatment also in your country. So I'd like to highlight the most important slides and information from the Ask for First trial in my view. So it's a phase 3 trial, it's multi-center, open label, randomized study of asciminib versus investigator-selected TKIs in patients with newly diagnosed CML. And what were the key inclusion criteria? Newly diagnosed, no prior TKI treatment, at least 18 years old. And there was a pre-randomization where also this was selected by the physician in consultation with the patient. And then there was a stratification also according to the risk score, the ELTS risk category. And therefore we had then all in all 200 patients being treated with asciminib and around about 100 patients being treated with imatinib and 100 patients with second generation TKIs. The primary endpoints were MMR rate after 1 year, after 48 weeks for asciminib versus all investigator-selected TKIs, and the MMR rate after 1 year for especially also for the group which was selected to imatinib as a randomized partner compared to asciminib. The secondary endpoints were the MMR rate at year 2, so in week 96, with the same criteria. Here you see that the demographics and the baseline disease characteristics were mostly well balanced, and but there is with one exception, because we had the possibility that the doctor said, okay, this is an elderly patient, I do not want to have him a second generation TKI, so that was the imatinib stratum. So we see that more patients in the imatinib stratum were over 65 with higher cardiovascular disease risk and lower ELTS risk. And that clearly reflects, in my opinion, the physician's preference for imatinib in these subgroups, which I find very rational as well. So you see here that more patients receiving asciminib than investigational TKIs are ongoing treatment at this data cutoff. So it's 18% of asciminib treated patients, clearly nearly 18% who are on drug, and versus 38% on drug. If you put them all together, the percentage is higher for the patients on imatinib compared to the second generation TKIs. Sorry. So this is the one of the most important slides because it reflects the primary endpoint of the trial, the MMR rate after 1 year, which was significantly higher for asciminib compared to all investigator selected TKIs, 67% versus 49%. And if we compare on the right-hand side, the imatinib stratum, this difference is at least higher, which was also expected. So what happened at this early important milestone, EMR, or early molecular response? So a response less than 10% on the international scale. At that time point, again, we saw already significant benefit between asciminib, what we see here. It's close to 90% versus 70% on all treatment. And also, if we look for deeper responses here, the MR4 rate, it's close to 39% versus 21%. And that is always significantly different, at least even at that early time point of 3 months. And what happens then at the end of this trial, of this evaluation of the trial, at least after 2 years, the deep molecular response rates, and I would like to concentrate just on this, on the left part here, that 49% on asatinib versus 27% on all other investigator-selected TKIs achieved MR4, and 31 versus 17% MR4.5. So that is a clear benefit of asciminib compared to those drugs who were considered to be the best of the best so far. Here we see another explanation or a depiction of cumulative incidence of deep molecular response that was clearly higher with asciminib than with all other TKIs. So I would stress on sub-factors, on prognostic subgroups across all demographics as well, and we see that in nearly all cases there's a favorization of asciminib. So either ELTS scores or sex or race or age or the cardiovascular risk category, they all profit from receiving asciminib. And here we see why this probably also is the case, because the safety and the tolerability continue to be more favorable with asciminib than with imatinib and the second generation TKIs by year 2. In the left part of this slide, we see 44% of asciminib treated patients experience grade 3 or higher adverse events, compared to 49 on imatinib and close to 60 on second generation TKIs. And this is here one of the most important information here, that only 5% discontinued then asciminib, that these adverse events led to discontinuation, versus in 13% of the other TKI groups, there was a discontinuation due to adverse events. Those adoptions and interruptions were also rarer in asciminib treated patients versus in the imatinib and the second generation TKI group. So if we look here, the comparison of asciminib versus imatinib, we see that 17% discontinuation versus 46 in total. And on the next slide, we see the comparison of asciminib versus second generation TKI. So it's comparable, it's 19% versus 30% discontinuation. And in many times it's due to unsatisfactory therapeutic effect. Here's a depiction of the most relevant adverse events, which were lower with asciminib, and you see there are some which tend to be a little bit higher, like thrombocytopenia, the grade 4, but not the grade 3 incidence, maybe a little higher, and but you will have difficulties in finding anything which is concerning tolerability, which is worse in asciminib than in the other TKIs. And that also reflects very stringently that all these common criteria like diarrhea, nausea, fatigue, headache, rash, you all know and you all have experienced these. It's all more rare with asciminib. So this is the ask for first summary that asciminib continues to demonstrate superior efficacy versus all investigator-selected TKIs, and MMR rates are as high as 76% in the imatinib stratum. The treatment difference for MMR rates increased from 8 to 15% after 2 years for the asciminib treated patients. The DMR, the deep molecular response rates after 2 years, remained higher with asciminib than with all investigator-selected TKIs. The safety and tolerability profile continues to be better than that of imatinib and the second-generation TKIs after a longer follow-up, and was consistent with its known safety profile from the first evaluation after 1 year. Twice the proportion of patients discontinued all investigator-selected TKIs due to adverse events compared with asciminib. Asciminib's favorable benefit risk profile compared with all investigator-selected TKIs, imatinib, and second-generation TKIs in patients with newly diagnosed CML reinforces the use of asciminib as a standard of care for this patient population. So let me at the end get some personal conclusions as well from the first part, as which I was talking about and combining many aspects of the previous speakers. So for me, it's very important to have a pre-treatment assessment of the risk scores of major root additional chromosomal abnormalities and atypical BCR-ABL transcript, because those are really important for the treatment choice besides comorbidities. The early molecular response, so a BCR-ABL expression level less than 10% at 3 months, predict for progression-free and overall survival on any TKI, not only on first-line therapy. For us, asking for comorbidities and side effects is crucial in order to address compliance, and avoiding side effects will be of utmost importance, besides of very good efficacy of the drug used. So we have a very promising combination of improved efficacy and tolerability by asciminib. Another great step to bring more CML patients to TFR, and this is my conviction that we have with asciminib the most promising drug, which combines the best of two worlds. We have the best efficacy combined with the best tolerability, and so I think it's on the best way to be the standard for all CML patients. So thank you very much, and I'm happy to take questions.
Thank you, sir, Professor Muller, for a very detailed talk on asciminib and clearly highlighting the differences with the current available options of imatinib and the second generation TKIs. And before we open to the questions, I just want to highlight for the audience again the importance of adherence. That the slide that was shown 90% compliance, which means actually, if you put it in numbers, that means if patient misses only about 4 tablets a month, that is less than 90%. So patient may not realize it is, that much a difference, and few tablets a month in a very long treatment, years of treatment, may not seem that critical to patients. So we have to keep highlighting that, which I do very regularly, address the compliance and keep stressing to them that this is very important, and that I put it in numbers, that just if you miss even 3-4 tablets a month, that brings down your success rate by 90%. So with that, let us open to the questions. Some of my panelists have already put their questions in the chat box, so I will just read it out. First question is from Dr. Preetam Jain. How soon could patients expect to attempt TFR with asciminib?
So, what are the expectations in which percentage of TF?
No, the question is that how soon can we attempt TFR on asciminib? Because the other criteria, we know that 5 years, you said optimal, otherwise 3 years and all. But with asciminib, can we do this earlier?
Definitely. And since we see the highest response rates, the deepest responses at an earlier time point, I expect that most of the patients will achieve an MR 4.5 within latest 3 years, and thereby can do their first TFR attempt much earlier than on the other drugs. So I think that is a fair assumption. And if we just follow also the ELN recommendations with at least 2 years of MR 4.5, that could in many cases already been done after 2.5 years.
So is there already data on TFR with asciminib?
Not that I know. So I'm not aware of that data, at least.
But based on this timeline, you're saying that at 3 years, it should be likely that a large number can attempt TFR. Because this is in the clinic, when we discuss, we would have to give them some idea that what are we expecting, especially young people for whom this is an important point. So the next question is a comparison of from Dr. Anup Toshniwal, comparison of ponatinib versus asciminib in T315I mutation positive CML.
So in second line or third line treatment, there was some experience about asciminib, and what we learned is that the dosage must be higher, and it's not the 80 milligram per day, but 200 milligram per day, which are effective to inhibit that specific mutation. And but the tolerability is astonishingly still okay, and not perfect, but it is okay. And compared to ponatinib, the standard dose of ponatinib is 45 milligram at the beginning, and as soon as you achieve a certain response, then it's recommended to reduce the doses down to 15 milligram in order not to get the risk of a vaso-occlusive disease or anything like that. And so both are doable options in patients where you experience this T315I mutation. And of course, more experience, since it was approved for ponatinib since years, is present for ponatinib. And but asciminib is absolutely an option in that situation.
Thank you, sir. Next question we have from Dr. Shyam Agarwal. Sir Advani, sir, you want to ask a question? Please go ahead. Yes.
Can I ask you, Dr. Muller, one question? Is with regard to we now see the data is better than the previous first generation or second generation. But do you think it is only because of the lack of side effect the lack of effect on the off-target, that means the adherence is better and therefore the results are better? Or is it the drug is better?
It's both. It's definitely the case that the drug is better because it's more specific and it hits better, inhibits BCR-ABL more effective. But the other point is very valid as well, because if you do not need to stop the treatment or pause and adapt dosage, of course you lose a response in these important early weeks and months. And so both topics are absolutely valid.
The next question is from Dr. Shyam Agarwal. Do we have data with asciminib in the high-risk categories of CML?
There have been patients included into the Ask for First trial, and I think they did not do a specific sub-analysis of only the high-risk group. I think that has not been done, and it was not in the statistical plan yet, but I'm very sure, and we are all keen, of course, on getting that data as soon as possible. As far as I know, it has not been looked at so far.
In the Ask for First analysis, subgroup analysis slide that you showed, the forest chart, where I think for all those asciminib was favored. So may not be detailed analysis, but as much as I remember from the slide, right?
It was, at least for that analysis, it was also favoring for the high risk group. Absolutely. Yeah. That's true. Mhm.
If the next one is from Dr. Jihan Davar, if asciminib is used frontline, what are the best second line options in case of intolerance or resistance?
So concerning intolerance, I would say this probably will not be too often, but resistance, of course, there will be cases. And I think it is fair to say that this patient then would need an ATP binding treatment, and probably I would go for ponatinib or for dasatinib, because those are really broad and dirty enough, not only to go for ABL, but probably only for bridging to a transplant. So if possible, if a donor is available, maybe at least I would go for a donor search in such a patient, because this would be a very high risk patient in my view.
How bad is the cytopenia? Any patients need to stop because of that, or at what point you reduce the dose for thrombocytopenia?
There are and we reported or talked about earlier a case who had this pancytopenia. Thrombocytopenia is really a pan TKI issue, and if you experience that on imatinib, chances are quite high that you will have thrombocytopenia on nilotinib and on dasatinib and bosutinib. But there are these cases who do not have thrombocytopenia with that history of maybe intolerance of four other TKIs, if they use then asciminib. On the other hand, it might be the other side around, because thrombocytopenia is at least one of the side effects which is quite prevalent according to the current trials.
Is there a
Dr. Chirag,
timeline?
Dr. Chirag, can I
Yes.
intervene here? Actually, we
Sure.
have experienced some of the clinical trials, phase 4 trials on asciminib in our center. So in one case of the T3155 mutations, we are using very high dose of asciminib. We have reported very great for thrombocytopenia, and we have to stop also the asciminib for timing as per the recommendation. So thrombocytopenia is an issue, particularly when you are using in the blast crisis, when you are using T3155 mutational very higher doses of 200 milligram. That's an issue.
Yeah.
Yes, sir, please. You're saying something.
No, I
Okay.
just wanted to say it is very plausible, and I think it's in these cases, I hope that that a donor will be available for this patient if he goes to resistance. Then
Right. But even in the T315I, we can use a lower dose if required, right? I mean, if we're able to balance, maintain the control, it is not an
Can I-
absolute must. Yes,
1 second, I need to close something here.
sure. Yeah, when I had a discussion with one other international faculty, I was told that it is not an absolute must to give 200 milligram in case there is intolerance. But if the PCR is maintained, then you can kind of even lower dose, you can maintain the patient. Just to, for audience to say that it's not an absolute must. Is that right?
That is right. And I personally do not have experience in really dose lowering because it was not necessary yet, but it is an option. And in case of intolerance, of course, I would do that.
Next question is from MB Chandrakant. Any subset of patients for whom we prefer imatinib or a second generation TKI over asciminib?
So for imatinib, maybe in a very, very old, frail, comorbid patient. This is my only patient group where I think of imatinib, of giving imatinib. There is no reason for me now to use nilotinib, dasatinib, or bosutinib as first line if I have access to asciminib.
Okay, so for younger patients, no comorbidities, there is for all of them asciminib as per your preference, right?
Absolutely. It's I want to hit hard and early. I want to get in deep response as soon as possible, and I do not want to harm them and take care of side effects, and I want to get them into treatment-free remission. So it seems to be the best of all worlds within that drug, to be honest.
Great. So I think that's very clear because so we don't have to remember what subsets to give, what not to give, what comorbidities to avoid. I think that's a very nice, easy to remember. So one other question is from Dr. Shyam Agarwal again. What are the mechanisms of resistance at molecular level post-asciminib?
What is the mode of mechanism?
Yes, mode of mechanism.
So I'm not a biochemist, but the mirrors to ill binding site obviously very specifically has been designed to be inhibited by that drug. But I do not have any insights on what that did with cell lines or so on. The only thing that I know, and I followed the situation of the preclinical data of asciminib as it had a different name, ABLE-001, that has been the cell lines, of course, are the first step of testing something like that before you can even think about treating a patient. And even that data was very preliminary and was very promising at a time point where nobody really believed, oh, why do we need that? Things are quite okay, but if you find something which is better, yeah. You should use it if it is affordable, and I know that that it is an issue, especially in India, but in many other countries as well, where you can not give every drug to every patient.
Thank you. Now, Dr. Agarwal has some other questions not clear. Atypical CML second generation TKI and CML accelerated phase second generation TKI.
So, that was in response to Dr. Chandrakant. So do we give for atypical CML, do we have the approval for asciminib? And even if a patient is presenting in accelerated phase, should we give asciminib or should we just restrict to CML chronic phase?
I think it is not approved yet for accelerated phase, but correct me if I'm wrong. I'm not 100% sure. I think in accelerated phase or blast crisis, also the recommendations of the ELN are in the direction to try either dasatinib or ponatinib to bridge to a transplant and not go with that very specific drug. But I'm not 100% sure, but maybe one of you knows that clearly.
Not sure about this specific recommendation. If any of my panelists are aware, otherwise we'll go to the
Yes,
next. Yes.
Dr. Chera, can I comment?
Yeah,
So far the
please.
accelerator phase or blast crisis is concerned, there was so far asciminib is concerned, there is a subset analysis also. They have analyzed blast cell more than 10% and blast cell less than, no, sorry, जो BCR able more than 10%, BCR less than more than 10%. They have found that this asciminib is much more effective if the BCR is less than 10%. So I don't have any idea about blast cell percentage and which correlation with the sensitiveness of the asciminib. I have a question to Dr. Martin. Since you have two stacks of drugs, one is ATP binding TKI, second in myristoyl pocket binding TKI, your asciminib. You have seen that of late various first generation and second generation TKI has been used in a reduced dose, like dasatinib at the dose of 50 milligram, even imatinib as a 200, 300 milligram, and the efficacy is much more better in compound because of the adherence and the less side effects. Similarly, do you think that combination of asciminib at both at low dose along with the other your first generation or second generation TKI will be certainly a very promising option in the future? Though this attempt was made in the ASEAN study, but the number of the patients are very less. So it could not have any statistical significance. And I'm sure many of the studies are going also combination of asciminib and other TKI. So what is your take in this case as a futuristic options of combination of the drugs? When you have a suboptimal response with either to asciminib or to other TKI, combining the both the drugs. So what is your take in this regard?
So I'm not sure if I got the point. You said it is a doable thing to increase in adherence in the other drugs, imatinib, second generation TKIs, to reduce and make people adhere, and thereby improve also the response, right? And for asciminib, I think we said it is not necessary in most cases until now to reduce doses, but it could also be a valid approach to do that in case of adherence problem with a good response. I think that can be transferred to asciminib as well if necessary. So we should never stop asking very thoroughly our patients if there is something that bothers them. And some of them might not dare to speak up towards doctors to say that this is a disturbing thing. But therefore we need to approach them because the big benefit is then for us to be able to help them better. And I think in the early years of TKI treatment, at least I was was not very sensitive with patients moaning about side effects, puffy eyes, and diarrhea, and because the notion was, hey, this is a deadly disease. You're getting your life is being prolonged by that, and that might not have been so important at that time because survival was the biggest challenge at that time point. And then we were maybe not so sensitive, but we need to be more. The longer treatments are over years, and everybody is managing patients with imatinib treatment, and it's getting more and more important on those patients at least to thoroughly ask them about these side effects. If it's possible, if the response is great, then of course there's nothing speaks against reducing the dose and making their life better and more comfortable and less stressful. And I think this is a big, it's very good for our doctor-patient relationship if we take care of that more and more.
Another point was combination of asciminib with other TKI in near future. That's
Yeah, I think that it's a valid option to combine because here we do not have the same target. We have the same target BCR-ABL, but not the same region in BCR-ABL. I'm not aware of proper combination studies so far, but in theory, it should work to combine in certain situations a TKI, a conventional ATP binding TKI with asciminib.
actually,
I
you know,
have,
Martin, in ASCENT study, even in ASCENT study, they tried also, they tried to combination of the, it's a phase 2 study, they tried combine the asciminib with the dasatinib, but the number of the patients are only 3 to 4. That's why they couldn't derive any result, but they attempted also in the phase 2 ASCENT study. Hopefully, there are many studies are going on, hopefully it will give a correct picture in the future.
we have
Very good, yeah.
a message from the Novartis team that as per the prescribing information, asciminib is not approved in accelerated phase or blast crisis. So it is only,
Thank you.
DCGA approval is only for chronic phase as of now.
Yes.
And so I think in the interest of time, now we need to give go over to Professor Advani sir for his closing comments. Sir, please.
Yeah, dear friends, I think today is the day when we have now accepted all over the world the challenge to change. I think that is the most important thing. There's so much of resistance to change because many of us are used to TKI in a way that we feel it's very safe without giving a deep thought about the side effects which the patient suffers. And sometimes, as Dr. Martin mentioned, that we neglect those because we don't interact with the patient much. So I think that is a very clear message that today the standard of care is asciminib, and hopefully it should be within the reach of every Indian, as it happened with the imatinib long time ago. And with that, we will be able to give the best of the treatment to our patients. So with this, I would like to thank all the speakers, particularly our esteemed speaker from Germany, Dr. Martin, who has given us so clearly that how the change has happened and how the data shows the remarkable difference between the effectiveness of this new drug. So with that, I would like to thank the Novartis for giving us this opportunity to interact and expose all our colleagues and ourselves to the new era that has come up in the chronic myeloid leukemia. Thank you very much.
Thank you, sir.
Thank you, everyone. Thank you, everyone, for joining on this Sunday evening. Good night, everyone. Thanks to all the speakers and the panelists. Thanks, Aditya, and thanks, technical support. Thank you, Novartis. Thank you, everyone, and good night, everyone.